Okay, well, good afternoon, everyone. Today I wanted to talk about yours, especially about yours. I'll say something about Buruli ulcer later. We have talked about neglected tropical diseases before, but I particularly wanted to talk about yours because I think it's an increasing and under-recognised problem. It's endemic in many communities in PNG. Recently, I saw a number of children that had yours, and they were not recognised as having yours. They were thought to have some other illness. They don't get the treatment they need, so it progresses to more bony destructive disease, and then the child has chronic disfigurement or disability, and it can be whereas if it's identified in the very early stages, then it's easily treatable. Even if it's identified sort of in the medium stages, it's quite a treatable disease with short duration of treatment. So it's a good diagnosis to make because you can treat it. But if it's undiagnosed, then it can be very disabling. As I said, I've talked before about neglected tropical diseases, and this is the World Health Organization list of neglected tropical diseases. And all the ones I've highlighted in green are prevalent in Papua New Guinea. So dengue and chikungunya virus, um, uh, leprosy still present, lymphatic filariasis not yet eliminated, scabies ubiquitous, uh, helminths, hookworm and other soil transmitted helminths also ubiquitous. Snake bite, a big burden of childhood injury. Trachoma still present, although not as much as it was. And then two I've highlighted in red, which I'll mention today, especially yours. As I said, something that people I think thought was had disappeared some years ago, but actually is still present, and Buruli ulcer, which is part of the differential diagnosis, and that's more or less why I'm talking about that a bit today. This won't take too long because there's um, just really focusing on yours today. It said in the 1970s, 60s, and 70s, it was said that yours starts where the road ends. And I think that's very true because the children, the villages where a number of children have yours in Papua New Guinea and in the Solomon Islands they're often very remote areas. So yours starts where the road ends. It's a disease of poverty and low socioeconomic conditions. Often people living in overcrowded communities in tropical or humid or forested areas where children aren't wearing anything on their feet. It's areas where there's limited access to sanitation or safe water or preventative and curative healthcare, and there's poor personal hygiene because of all those things. The ulcers themselves, when a child gets a Yaws ulcer, they contain many organisms, many spirochetes, and so they're spread from child to child very, very quickly. And it's not uncommon to find several children in a household with Yaws, and then other children in the village, in the community, also having Yaws at various stages of severity or various stages. There's a, three stages of yours, a bit like syphilis. The incubation period's sort of long. Once in a child who's exposed to yours by direct contact, then it can be 2 to 8 weeks before they start to show manifestations of it, get the ulcer themselves. The primary stage is this painful sore on the skin, and that's highly infectious. As I said, the ulcer contains many spirochetes in it. The secondary stage often involves lots of papillomas, or like papillomas just being not ulcers but raised lesions on the skin. And then it can be quite painful. The secondary stage can be painful because there's an infection that involves the bone, but often there's a latent period where nothing much happens. So the painful papillomas are there, some ulcers are there, but the child doesn't progress any further. But then there's a late stage or a tertiary stage, which is not infectious, but there's often osteolytic bone lesions, destructive bone lesions, and destruction of the cartilage. So yours affects the skin, the bone, and the cartilage, and that can lead to scarring and chronic joint abnormalities. As I said, it can lead to severe disfigurement and disability. Whereas if yours is picked up in the primary stage, it's much more treatable. Even the secondary stage, it's quite eminently treatable and can prevent the disability from occurring. This is a primary lesion of yours. You can see it's a raised lesion. Often they're on the legs, on the feet or the legs, but yours is due to a a spirochete that's a bit like the syphilis bacteria. Of course, it's not sexually transmitted, not vertically transmitted, but just transmitted because of sores and children, direct contact with children. It is endemic in Papua New Guinea and the Pacific Islands, especially the Solomon Islands. Certainly the 19% of children in Western Province, not in the Solomon Islands, were TPHA positive, and that suggests that they're not all. Very few of them have syphilis, but most of them would have been exposed to yours at some stage. About 5% of these children in a large survey in Western Province in the Solomon Islands, about 5% had evidence of bony lesions from yours. So it's actually quite, of those 19%, 5% had bony changes of yours. As I said, it affects the skin, the bone, and the cartilage. Obviously, if yours affects the cartilage doesn't regenerate like bone does, and skin does. And if yours is affecting cartilage in the joints, then there'll be chronic joint disfigurement and chronic joint immobility or bony fusion or arthritic changes. These are more typical primary ulcerative lesions, and you can see they look different. They're different to a Buruli ulcer, which I'll show you. I'll show you some pictures of that. They're not as punched out as a Buruli ulcer. They're more flat on the skin or even raised. You can see even raised, but there's clearly an area. Sometimes they said to look like a raspberry, and probably that's a bit true for some of these lesions. This lesion is sort of primary going into a secondary lesion with a nodular. It looks like a primary lesion, but you can see the raised elements of it as well. So primary yours looks like this. It's said to be look like a strawberry lesion. Many children have more than one of these, and certainly by the time they get to secondary yours, they can have multiple of them. This is more advanced, much more advanced yours in a child who has child I saw recently who has severe tertiary yours with bony destruction. It's a bit hard to see from this photo, but you can see there's elements of destruction of the skin, that you can see the lesion on the ankle or just above the ankle, and other lesions, and there's actually a fusion of the toes because of the osteolytic lesions of the digits, and this can be very severe. As you can see, the effect on the especially the small bones of the hands and the feet, particularly. I mean, it does affect the long bones as well, but the small bones of the hands and the feet can be particularly affected and lead to destructive bony changes, cartilage damage, and sometimes fusion of joints, and very can be very disabling. You can see there the fusion of the toes from severe yaws that has been going for a long time, and you can see the secondary effects or the associated effects of children who are living in poverty with a chronic illness or a chronic infection, and that is this child's also got severe malnutrition, has got severe zinc deficiency, severe iron deficiency, anemia, all from both the chronic infection of yours, but also the associated problems. That doesn't help. This girl and her sister are getting much better with proper treatment for yaws and treatment for their severe malnutrition and their iron deficiency anemia and their zinc deficiency, etc. All of those things will be need to be treated in such a child. This is the sort of X-ray changes you typically see in secondary yaws when there's involvement of the hands, and there's a arthritic change or an osteolytic change called dactylitis. This can also be seen sometimes in Mycobacterium tuberculosis. In TB, osteomyelitis of the hands, you can see a dactylitis as well. But you can see the osteolytic lesions of the bones of the small the metacarpals and the interphalangeal the phalanxes of the hands. All the small bones of the hands are affected in this situation, and when it gets to sort of tertiary yaws, there's subcutaneous nodules like you can see in this child. So secondary onto tertiary yaws, this is what it looks like. Even more extensive. This is another child who's got. You can see it's not osteomyelitis, which usually affects one bone or one joint or one or two joints, but it's an overall effect on all the bones. You can see this with severe yaws dactylitis, and the same for the feet. If you take X-rays of the feet, then you'll often see these changes as you could in those other two girls that I showed you before. The differential diagnosis of yaws is many of the other things we think about. So Mycobacterium ulcerans, which I'll talk about, the Buruli ulcer, sometimes called the Bairnsdale ulcer. I'll talk a bit about that. Just tropical ulcers in general. Children who live in tropical environments, if they get a scratch, they might get an anaerobic infection or a staph infection, or a enteric gram-negative infection in the skin. That can occur from any sort of trauma, like an infected scratch or a trauma or an insect bite or anything that damages skin and then it gets infected, so-called tropical ulcer. Leprosy is also in the differential diagnosis of yaws, and one of the patients I showed you before, they were thought to have leprosy, but actually it's not leprosy. It's just yaws, and then more advanced forms of syphilis, congenital syphilis that has been untreated, can look quite a bit like yaws, including the bony changes. That you can make a clear diagnosis based on the clinical picture, on X-ray appearance, and on the serology. So the TPHA stays positive for life in children who've got yaws. And so finding a positive TPHA means the child's either been exposed to syphilis or exposed to yaws, and and whether they've been treated or not. But it still stays positive. The VDRL becomes negative if you treat the yaws successfully, but the TPHA stays positive. In the early stages of yaws, like primary or even early secondary yaws, you can swab the ulcers. If you get a moist swab of the ulcers and look at it under dark field microscopy, which I'll show you a picture of. The ulcers, the organisms, the spirochetes, they become very prominent on that. And although that's rarely done, it's worthwhile because you can actually confirm a case of yaws. But a child who's got clinical ulcers that look like yaws, they're not. I'll show you the Buruli ulcer shortly, the more punched out ulcer, more destructive ulcer. But a child who's got a yaws-like ulcer with a positive TPHA and a positive VDRL, then it's very likely to be yaws. But if you can do a moist swab of the ulcer, you'll be able to see it. This is what it looks like under dark field microscopy. Dark field microscopy is I've mentioned it before when we talked about leptospirosis, but it's a microscope with a special condenser on it that obliquely or tangentially directs the light towards the specimen, and the background is dark, sometimes called dark ground microscopy, and the bacteria show up as sort of bright lesions like this. This is the yaws bacteria that you can see in dark field microscopy. it works well in primary yaws because those ulcers are full of the bacteria, not so much in tertiary yaws. But tertiary yaws you can diagnose based on the positive VDR or positive TPHA, the X-ray changes, and the clinical picture, and especially that you could see the changes in the bones and the fusion of the bones, suggesting bony destruction and cartilaginous destruction. There are some other tests, PCR testing for yaws, but they're not always available. I think they mostly can be diagnosed based on a clinical picture and a positive VDRL and TPHA. The treatment is very effective, and for years we used benzathine penicillin. The long-acting penicillin lasts for about 28 days. Um, just a single dose of intramuscular benzathine penicillin to a child who's got a primary yaws will be effective. The What's been shown to be equally effective and not uh, so you can avoid injections is azithromycin. You need to give a higher dose of azithromycin than is usually given. Normally, if we're treating, say, a pneumonia, that with azithromycin, we'd be using 15 milligrams per kilogram every day for 3 or 4 days. But the dose for yours, a single dose, is 30 milligrams per kilogram, up to 2 grams of azithromycin. Um, uh, in a child like I showed you with tertiary yaws, I think it makes sense to be treating for a longer period of time. The If WHO says that if there's less than 5% of people in the population or children in the community that have yaws, then you just treat the immediate family. So they all should get treatment with azithromycin. Um, Treat the immediate family and the household members. If there's somewhere between 5 to nearly 20%, then treat all children in the village and any adults who've got the clinical disease. And if there's 20 or more percent, then treat all the community children and adults. And there's many villages in PNG that are remote, but somewhere between 15 and 20% of the children have 5 and 20% of the children have yaws. So it would be an argument for mass drug administration with azithromycin in many of these communities where yaws is found. I wanted to just show in contrast a Buruli ulcer, and um, Buruli ulcer also found in PNG. It's most previously reported from the CPIC has been where there's been Buruli ulcers, but you can see it looks a bit different to a Yaws ulcer. It's very punched out. It can look like a nodule on the arm or the leg to begin with, and then it ulcerates, and after 4 weeks or so, the ulcer sloughs off, leaving this sort of deep, painless ulcer, and it's got this sort of yellow or red base, and it's the uh, the Buruli ulcer occurs because Mycobacterium ulcerans produces a toxin that erodes the skin, called myolactone. It erodes the skin and the soft tissues, and it usually occurs because of contaminated soil or the bacteria grows in stagnant water, and so again particularly on the north coast in the Sepik, there's Buruli ulcers have been shown. The Buruli ulcers occur in many countries around the world, and they usually occur where there's mosquitoes and also where there's some sort of rodent or small marsupial, like in Australia, they're possums, maybe cuscus in PNG with mosquitoes, and the possums seem to be the intermediate host of these of Mycobacterium ulcerans. So having stagnant water or contaminated soil and a small marsupial of some sort and having mosquitoes is a breeding ground for Buruli ulcer. There was many cases reported in the East Sepik some years ago, mostly in small children. The differential diagnosis is Yaws. It's staph ulcers even diphtheritic ulcers, not so common anymore. Fungal infections or fungal ulcers or tropical ulcers, as I mentioned before. You can see in these, if you're taking a swab of a child you're worried might have yours, and for dark field microscopy or to investigate for Buruli ulcers, then you can do an AFB stain on it and find it's positive on Ziehl-Neelsen staining. These patients usually get better when they've had rifampicin and clarithromycin. So it's a macrolide as well for 8 weeks. There's some other options, ciprofloxacin, ethambutol, azithromycin. They're all options, and I guess that they'll treat both. That will treat both Buruli ulcer and yours. So if you're uncertain and you can't do microscopy to confirm the diagnosis, then using azithromycin will be effective. But I think you can usually clinically make that distinction between Buruli ulcer and yours. Look, that's all I wanted to say today. In a way, I wanted to present this because that yours, I think, is increasingly common. It's under-recognized. I think the pediatricians and registrars, we all need to know about yours and have a heightened level of awareness of it. So that's all I want to say. I'm going to stop the recording now, and I'm happy to answer any